Today's conversation focuses on palliative care for cancer patients, exploring the true meaning of comfort, compassion, and quality of life in treatment. Today, we are joined by Professor Auxilia Munodawafa, a distinguished nurse scientist and health policy consultant with over 5 decades of experience across Zimbabwe and the USA. A former director of palliative care at Cleveland Clinic and current member of the Zimbabwe Cancer Registry Advisory Committee, Professor Chideme Munodawafa brings a wealth of expertise on how palliative care transforms both patient and family experiences in cancer care. Palliative care for cancer patients is what we're going to be talking about. So welcome, Professor.
Thank you very much for having me.
You know, this is, I was enjoying going through your, I know we shortened it, but I was going through your experiences, everything that you've done in the USA, in Zimbabwe. There's so much impact that you've had. But let's just talk about palliative care. What really is this? Palliative
care is an integral part of caregiving in Zimbabwe and in the world over. It focuses on particularly quality of life, improving quality of life to the best capability. When it comes to cancer patients, you are not increasing the days they live, but you are increasing the quality of life that they will live while they are going through the treatment or the chronic illness that they have. And in fact, it's for all other patients other than cancer patients. Palliative care should be applied to right at the beginning when a person is diagnosed with a chronically terminally ill condition that is not curable. They should have palliative care as part of their care.
So we're talking about improving someone's quality of life when we talk about palliative care. How is this done, especially like when you are looking at our hospitals in Zimbabwe? How exactly is this? Can palliative care be given at home, or is just like when we're looking at here?
Palliative care focuses on symptom management, particularly pain management and all the other symptoms. So this is how you improve the quality of life. And it focuses not only on the patient. Palliative care is a multidisciplinary component that focuses on the patient and the family, because you are also addressing the needs of the patient and the family. Because when a person is sick, even in our culture, it's not a one-man band. It becomes a family unit issue. So it's basically embracing even the cultural approach that we actually addressing in our culture. Is when one person is sick, it's everybody who is involved. So the same applies with palliative care. You are trying to incorporate the patient's needs and the family's needs, because they are almost one and the same.
Right. And you know, before we went on air, we were just discussing about how palliative care is also part of our culture, which you have also just mentioned now, to say that it's something that has been practiced long before. Could you just share what that has to do? Because, you know, when I was reading around, some people were saying that palliative care is given to people that are about to die. So when you find out that you are being given it, it means you've been like, people are like, okay, we are done with you.
Yes. Palliative care has existed time immemorial, but without the name behind it to say it's palliative care. I grew up with my grandparents, so in my discussion with them, they would tell me that in the past, when a person was sick, when they became very sick, they were taken out of the village, so that in our culture, death was very secretive. Even children were not supposed to be exposed to that. I think one of the reasons why a person, when they became critically ill, were taken out of the village was to nurse them separately. And the care was given by not everybody. They were identified menopause ladies who would take care of the day-to-day needs of that particular person. They would take care of the cleanliness, they would take care of the nutrition, and the medications for pain and other issues were under the guidance of a herbalist. Using basically probably some of the medications that we now have, but that have been refined and given a name, but that have existed as herbs within our culture. So palliative care includes that component of cultural participation, whereby the whole family is also involved in the care. So with palliative care, as a nurse, as healthcare workers, we are not only dealing with one person. We have to remember that we are dealing with an entity, the family.
And do we have the capacity, Prof? Do we have the capacity? Because I'm looking at all the hospitals. Do we have what can we do to embrace and make sure that we are also dealing with the whole unit and not just the patient?
You know, what I'm saying has always happened, but without a name under it, we have always taken care of individual patients, and we know that they are brought by their parents, they are brought by their children, and we will be communicating with them as nurses especially. Nurses are like 24/7 at the bedside. They will be the ones who interact with the family, who interact with the patient. Sometimes when you are dealing with even pain management, you get pain scores from the family members because they are there. And you as a nurse, the doctor will come and see the patient and go. But as a nurse, you are always, we call it 24/7, you are there. You give handover and take over, but there is always a nurse there. So as a nurse, you are dealing with the patient and the family, and you look at both needs. It doesn't require extra hands for that to be achieved, but it requires education so that we disperse the myth that when you are referred to palliative care, you are dying. Palliative care is for symptom management, and symptom management can be done alongside with curative care. So the very same person, nurse who is doing a curative care, is also part and parcel of doing palliative care. So wherever there is a patient, a nurse and a healthcare team that are looking at that particular person, they will also be they will be implementing palliative care, maybe unknowingly,
but already doing it. So
it's part and parcel of care.
Yeah, and nurses, you mentioned that nurses play a major role in making sure that they provide palliative care, which they've already been providing since time immemorial, but now we are giving it a term. What role specifically do nurses play besides what we have mentioned, like tracking symptoms?
Yes, as I've mentioned already, when we give it a name, there are some extra knowledge that the nurse needs to know so that they implement palliative care in its totality.
Please don't move an inch. We're right here on the doors talking about palliative care for cancer patients. Thank you for staying with us. You are watching The Doors, and we're talking about palliative care for cancer patients. And Prof, before we went for break, I caught you when we were discussing the issue of nurses and the role. And I feel like it's something that you're also passionate about as a nurse as well. So let's talk about it. Let's break down the roles that nurses play with regards to palliative care.
Palliative care. The nurse, as I have already mentioned, is by the patient's bedside 24/7, which means 24 hours a day, 7 days a week. They are the ones who become intimate with the patient as they are taking the history, communicating with the patient. If the patient is not able to communicate, it's your role as a nurse to establish rapport with the patient, with the family. Because it's important for you to, once you establish rapport, they can open up, you give them space. I always say to my nurses in the yesteryears, the most important thing is to be present. You may not even be necessarily talk, but to be present, be available for the patient and for the family. That way you create a window for them to be able to ask questions, because the diagnosis of cancer is something else. There's still research going on about cancer. So when a person is diagnosed with a cancer, the patient and the family, they need to be given that open window to ask questions, to establish, themselves, and really internalize to say, okay, this is what is happening, and all the emotions that go through when a person is diagnosed with a cancer. The nurse can be the person that is by the patient's bedside and the family's availability. You are also the person who is making sure what the patient eats, the medications. If the doctor orders those medications, you are the one who is making sure that they are taken. And the pain, you are assessing the pain, you are reporting to the doctor. You are the bridge. The nurse is the bridge between the other healthcare providers and the patient and the family.
So, Prof, this gives me a question to say that, are all nurses equipped to offer palliative care? Because it feels like this requires a certain training or experience. Is there?
They need, I can even say it can even start from on-the-job training. They need the knowledge to acknowledge their role. They need to know their role, to say, okay, as much as you are busy, but you need to give that. It's difficult, it's not easy. You said earlier on, do we have that capacity? It requires time, but when you are conscious that this is your role, you need to listen to the patient rather than tell them. Because in the past, we have always, as healthcare providers, prescribed to the patient to say this is what is going to happen. But palliative care requires that you have an ear, you include the patient and the family in decision making of their care. And you need to give them the chance to ask as many questions as they can, because all that builds up to quality of care that you are providing to that particular patient and family. And then, there are certain values that people have with regards to their families, or maybe it might be religion, it might be anything. Is there a part where palliative care clashes with people's cultures, and then they're like, and things like that? How do we get to that balance? This is where communication comes in, because palliative care is centered. The glue to palliative care is communication, effective communication between the patient, the family. Because when you have effective communication and when you offer your presence and you listen, you get to know their cultural practices. There are cultures, I will not mention a name, there are cultures that do not accept palliative care, that do not accept hospice care, that say nature should take its course. If a patient is diagnosed with an untreatable condition, let them be. So the most important thing is you not, as a healthcare provider, not to violate this is where ethics comes in. Because if you force yourself into the prescription or whatever it is that you want to give to the patient, you are violating their autonomy. But yet you need to explain to them all the alternatives that are available. That way you are respecting the ethical principle of justice, because everybody should have equal exposure to whatever is available. So there are ethical principles like also beneficence, non-maleficent. You don't do any harm. You maximize the best of care or whatever options are there for the best quality of that your patient.
So in my words that are not experienced, I'm saying if I am a nurse, excluding myself from the decision, but giving communication and enough information to make sure that the family makes the right decision for the patient.
You are not exactly excluding yourself as such, because you should offer options. So you offer them options to say this is what is available. And then you leave it to the patient and the family with your guidance, with the guidance of the healthcare team. But you are not forcing or you're
not recommending to say this is the best.
This is what you should do. No. You are saying these are the options that are available. And then you give them you respect the principle of autonomy in ethics. You give them the decision, the chance to make their own decision.
And there are people that are like, I don't want to step into a hospital. Yes, I have cancer. Yes, I need palliative care, but I don't want to step in a hospital. How do we bridge that?
The good thing is palliative care can be offered at all levels. We can have, in those countries that are well resourced, as I said already, they have palliative care units. Where I was working when I was in the US, I was director of palliative care, but within an intensive care unit that was offering consult services for palliative care. You can have a whole unit that is again dedicated to palliative care. Palliative care can be given at home, because again, going back to our cultural history that I mentioned, the idea of taking a person from the village to the Musasa made them be surrounded by their family members. They would dictate that I want to be buried at such and such a place. I want to see so and so. I haven't seen her or him in a long time. Where you would hear people saying, "Akamirira ningi kutafe." That is a conducive way of dying, where you are dying among your family surrounding. So palliative care can be given at home in the community. Palliative care can also be given as an outpatient service, so it can be given anywhere.
Anyway, all right. Thank you, Prof. We'll come back to that. Please don't move an inch. We'll come back with more right here on The Dose. Thank you for staying with us. We're talking about palliative care for cancer patients right here on The Dose, and I have Professor in the house. Prof, I am so much knowledge, and you know, after this, I know we're going to be empowered, because I am also feeling empowered to know that I can offer palliative care to some of my relatives who are going through this diagnosis. So let's talk about, do you have personal experience with regards to palliative care? Because it's different when you are a health personnel and you're offering and you're advising and training others, but it's also, it's different from experiencing it firsthand. Let's talk about that.
I do have several experiences, although at the time when I was going through the experiences, I don't know if I performed as well as I should have. But I have three brothers that are late, and the first brother got sick in 1991 into 92, just before I left for my master's program. And at that time I wasn't that geared. I had just gotten a bit of palliative care through hospice. But he ended up being admitted at that time quite a few nursing homes were springing up. He ended up being admitted there with our discussion and family members agreeing to that, and was admitted there and ended up going home. So he would be admitted at Pari. I was still at Pari. He would come to Parenya for acute care, and then he would be discharged to the nursing home, and then he would eventually go to the house. And that was quite an experience. I was happy to have known a bit of what I knew then, because we were acceptable as a family to have him transferred to a nursing home.
Right.
And eventually going home, because we would, fortunately his wife then was a medical doctor, so in between the pain management we were tossing it back and forth. There are a total of 2 nurses,
yeah,
and the doctor who was the wife. So we managed to agree first of all to be open to palliative care. It wasn't a myth for us to say, in our case, yes, we knew it was towards his end of life, but we would have accepted that palliative care even if he was getting curative treatment, because of the knowledge that I had, which is very important for the rest of the community to separate between palliative care is for those who are end of life, who are dying, and symptom management and pain management, achieving quality of life,
right,
within that period where you are living with the chronicity of the disease.
And let's talk about the research that you did. You worked on a whole, the word is skipping, is it a manual? You will correct me, where people are using that information to be trained in palliative care. Yes. Let's talk about that.
When I went for my master's, this was 92 to 95, I did a dual major, and one of the degrees that I did was the nurse practitioners program, which required a specialization. So I specialized in palliative care because I had gotten a bit of it when I was here through hospice care. So when I came back, Zimbabwe Open University was starting then, and I was now teaching at the University of Zimbabwe. They sourced out people who would write modules. And
so let's get into the actual modules to say what information was in there.
The module that I have, that I wrote for, it starts with the history of palliative care. It then describes what palliative care is, which areas you asked earlier on whether it can be given at home. So it describes the levels of care where palliative care can be implemented. It also discusses the role of the nurse in depth to say what your role as a nurse, the importance of you being at the patient's bedside 24/7. And you being the person who support the family and the patient, who refer them to counseling and other resources. The patient expects those resources to be channeled through you as a nurse. So I talk a lot into the role of the nurse, and I also then go into symptom management, starting with pain management, and then go into the rest of the other symptoms that can be managed within palliative care. All that is meant to improve quality of life without increasing the days of the patient living, but improve the quality of life that they enjoy while they are either being curatively treated or they are being taken care of towards the end of their life with a disease that cannot be treated, cured.
Yeah, and we're also saying, I'm just borrowing the words that you said, we're also not saying that if someone is offered palliative care, they are going to die. We're not sending them to their deathbed, but we're saying life, to improve the quality of life as they're going through
the main
diagnosis.
Yes.
And most people can actually get cured or live longer.
You can be cured even when you have been in palliative care. You can also live longer, but the focus is the quality of life.
Yeah.
That is what palliative care focuses on. It focuses on improving quality of life by managing symptoms such as pain and other symptoms. It can be a congestive cardiac failure patient who need oxygen and other things that they will need while they are being treated, either curatively or managing the symptoms. Yeah.
And we were talking specifically of cancer, and we talk of chemotherapy and other, is it radiation and other management of curative measures that are taken. So we're saying that when someone is going through that, they can also then receive palliative care to manage.
Exactly.
Yeah, let's
this
talk about
is
that.
why I said earlier on, palliative care can be, it's part and parcel of care within the healthcare system. So when a person is diagnosed with whatever chronic illness that they are having, palliative care should be incorporated. The World Health Organization came out with a different definition of palliative care. Within my module, I actually have the diagram. Initially, it used to start towards the end of life, but the World Health Organization came out with a diagram that starts at the point of diagnosis. Right. Palliative care then increases until at the end of life is the maximum care.
Right.
So which shows that palliative care can be provided alongside with curative care.
Oh, that's really awesome. And your knowledge is really in depth. The thing that's jealous right now is time, but I want you to just share something that you want our viewers to remember with regards to the conversation that we've had today.
I just want to emphasize that the myth about palliative care being for the dying should be long and gone by now. Palliative care focuses on quality improvement through symptom management, especially pain management and all other symptoms that a person goes through, either because of the side effects of the disease or the treatment that they are receiving.
Yeah.
So whenever you hear palliative care, please, it's part and parcel of the integral standard care that is offered in all settings in the country.
Yeah.
It should be received with open arms.
Today's conversation reminds us that compassion and communication are as vital as medicine itself. We hope you, our viewers, now see palliative care as an empowering part of the healing journey. Until next time, pleasant viewing.